So here we have our one and only Dr. Senthil sir.
Good afternoon, everybody. It's indeed a pleasure to be here this afternoon. It's a lovely team. I think you can't have a better team in palliative care than what we have today. I think when you see the kind of care that we should be giving, they are a classic example of how you should be taking care of people. Be with them, do that journey with them. I think that's very, very important at the end of the day, because as much as I tell all my residents when they join me, it's not just the beginning of the journey, it's not just through the journey, but how that journey ends is very, very important. Because I see that so many of our patients come back to us after their kith or kin, whoever was being taken care of here, have passed away, to tell us that they're thankful for the way that you helped them die. I'm repeating that. We're thankful for the way that we helped people die, because as much as all of us want to live with dignity, it's extremely important to die with dignity. So, అమ్మ తెలుగు అర్థం కాలేదు కదా, నాకు తెలిసిన తెలుగులో నేను చెప్తాను. ఎంత గౌరవంగా మనం బతకాలనో, మనం చనిపోయేటప్పుడు కూడా గౌరవంగా చనిపోవాలి. సో అది వీళ్ళ వల్లనే అవుతుంది. మేము ఎక్కువ పేషెంట్స్ చూసినప్పుడు అంత టైం స్పెండ్ చేయలేకపోతాం. పాలియేటివ్ కేర్ అనేది చాలా అంత టైం తీసుకొని పేషెంట్స్తో కూర్చొని వాళ్ళు చెప్పేదాన్ని విని, వాళ్ళు చెప్పేదాన్ని అర్థం చేసుకొని వాళ్ళకి ఏం చేయాలి అనేది చాలా అంత ఈజీ పని కాదు. అది మేము క్యాన్సర్ ట్రీట్మెంట్ చేసేదానికంటే కష్టమైన పని. ఇన్ఫ్యాక్ట్ మెనీ టైమ్స్ ఇట్ కెన్ సమ్టైమ్స్ బి వెరీ టాక్సింగ్ అండ్ అన్రివార్డింగ్ ఆల్సో. అది చూసి వాళ్ళు మనం ఎంతో ట్రై చేస్తున్నాము, అయితే కూడా పేషెంట్స్ హ్యాపీగా లేదే, అయితే కూడా నొప్పి తగ్గలేదే అని వాళ్ళు ఆలోచించడానికి మొదలు పెడితే చాలా కష్టమైపోతుంది. ఆ పేషెంట్స్ అండ్ పర్సివరెన్స్, డెటర్మినేషన్ అనేది ఎంత పేషెంట్స్ ఇంపార్టెంటో అంత పాలియేటివ్ కేర్ టీమ్ కూడా ఇంపార్టెంట్, అండ్ దే ఆర్ ఎగ్జాంపులరీ అండ్ ఎక్సలెంట్ అట్ దట్. సో ఐ ఆల్వేస్ బీన్ అన్ అడ్మైరర్ ఆఫ్ దట్ గ్రూప్ ఆఫ్ పీపుల్. అండ్ దీస్ two kids who are here, right, I think they are just made for palliative care. I've never seen them frowning. I have never seen them raise their voice. They're always smiling every time and any time that you see them, and they're always willing to do something for every and any patient that you want them to see. I think those are very unique characteristics that all doctors should have, and more so palliative care physicians. And from that standpoint, I think all of you are very gifted to have good residents like the two of them, and I'm sure they will also grow up to be excellent physicians and very good palliative care physicians, which is very important, because I think that's a facet that's missing very much in our country. It's financially not rewarding, so not too many people take to this. But the fact that majority of patients in our country are diagnosed very late with cancer, all of them at some point in time will need palliative care. The other myth about palliative and pain care, a couple of them that I would want to specify before I hand the stage back over to them, is one is that pain and palliative care should not come at the very end. It should start at the very beginning. This is extremely important, because as much as cancer treatment is being done, symptom care and many other things that we as physicians don't look at should also be taken care of. So it should start at the very beginning, not start towards the very end, because if you start towards the very end, it's extremely difficult for them to understand patients. It's extremely difficult for patients to trust them, because they have somewhere come into the care, and the people who are caring for them all the while have just left them high and dry. That feeling should never be there in the minds of patients. So this transition has to be very smooth. So if it has to be very smooth, they have to be involved from day one. So that's extremely important. The second thing is that morphine is always associated with terminally ill people and death. I think that's another myth that we should immediately remove. Kushi came and spoke here. What did she say? She said, the moment I came here, my pain went away. Pain could have gone away because of the cancer treatment, but I think it's extremely important that they must have used some really good, effective, within commas, powerful painkiller right on day one to relieve her of her pain. If we associated that narcotic painkiller with being terminally ill, and if we were using paracetamol, I don't think Kushi would have been comfortable here. She wouldn't have been Kushi. Right? Kushi wouldn't have had Kushi then, I suppose. So I think these are some of the myths that we have to dispel, not only from patients' mind, but also from the minds of physicians. Right? Because the moment you say, we have so many patients who are doctors, the moment you tell them, no, go to them, they will give you morphine, you will have good relief, they will immediately say, oh, no, I don't want to take morphine, because morphine means you're on your way up. Morphine means addictive, morphine means side effect, and morphine is always associated with negative things. I think as nurses, as patients, caregivers, as doctors, as palliative care physicians, the onus is on us to stress upon the fact that this is not the right thing to do, and we should tell them that this is the way to go about managing these patients, and it's extremely important for us to take care of them well. When I come back to where I started, it's not the journey only that matters, the end matters as much as the journey itself, because we don't want anybody, we're not claiming that we will save everybody who walks in here, but we have to ensure that everybody who comes in here goes out comfortably and happily and content, that not only they, but also everybody here who took care of their kith and kin did their best to make them comfortable. The end is not in our hands. We have to do our best. But how you did it, what you did, and how comfortable they were during their journey here and the way out is, I think, a very, very important part of treatment. So these guys are doing it with exemplary, capability and courage. Keep doing it. We're all there behind you. Anything that you need, let us know within our capabilities, and whatever we can, we will certainly make sure that that is done to make your life more comfortable as much as you're making your patient's life comfortable. Thank you so much, and good luck all of you.
Thank you so much, sir, for your kind and inspiring words. We are very grateful to learn from teachers like you all. So next, call upon Dr. Dilip, sir, Senior Radiation Oncologist.
Senthil sir, so it will be very difficult also. So actually the palliative care department, it was long overdue for us, and then happily we have it now. I think it's been more than a year. I think Sham should also be congratulated along with Praveen, Praneeth and everybody here. Okay. So once you listen the word cancer, that's where everybody heart stops. Even for a doctor and a family member, you hear about someone having cancer, your heart stops. So the dreaded word, once you listen, that's where we have to take it forward. So you should understand. So the trust starts from there. You counsel the patient, talk to them. So in the long journey, as sir said, you become a family member of the patient also. Because you see patients coming after 3 years, 4 years, 5 years. You do see patients coming after 7, 10 years also. So you're a family member. They try to share everything with you. Okay, the trust deficit should not happen when you're taking care of the patient. See, bringing the palliative care at the early, the trust is where you are building up, and then when you hand over the patient or when they go through the palliative also, so they saw the doctor, so they understand, and then they also take care of the patient in a holistic way. The empathy is one which is very important. You have to go into the patient's shoes or the family member's shoes and understand what they're going through. So, and then encouraging them to understand what is there, and then bringing out from the denial, and then making them to accept that you have cancer. The phase between the denial and the acceptance is where a lot of communication, miscommunications, alternative therapies come into picture. Why I will have a cancer is what the question most of them ask. Okay, so once you accept that I have cancer, from acceptance to going through the therapy to the eventuality of dignity of death will be the most peaceful thing. And then this is where both the physician, who is a primary caregiver, as well as the palliative care team comes in. During the phase of denial to the acceptance, also the palliative care plays a lot of role. So they will be counseling them. Okay, communication is most important thing which happens between the patient and the doctor. and then palliative people are really trained in doing that communication part. The primary caregiver, oncologist, mostly we try to, because of the workload or something, we communicate to certain extent, but beyond the extent of taking care of the finances part, family, caregivers, how to support them, all this is most of the time taken care of the palliative care. And we have to understand, especially for patients who are terminally ill, what are their unfinished businesses, what they have to take care. So as a primary caregiver, you have to tell them that probably this is the time you have. So if they want to get their kids to be married, some unfinished financial business to be taken care. So you have to give them the heads up that you have to start doing it so that once you pass away, they should not have any problem. So palliative care also will help, and then this excellent team would really come into picture there, and then they do all these things. So I really congratulate them. Hope we go much glory, high glory, and then we become the best palliative care team in India. Congratulations and thank you.
Thank you so much, sir. Now we'd like to invite Dr. Tasneem ma'am, consultant radiation oncologist.
Good afternoon, everybody. Palliative medicine is a people-oriented, people-centric health service. It means that along with the physical pain that they experience because of various conditions, be it cancer, chronic illness, whatever it is, other components which can lead to issues like physical, mental, psychosocial, spiritual, all these needs to be addressed, and all these are usually taken care when they come to the palliative healthcare services. Now, 8th October is celebrated as a World Hospice and Palliative Care Day. I think it's an excellent public platform where we can connect with the patients, the doctors can connect with the patients. This platform helps us to understand the importance of starting the palliative care journey much faster, from diagnosis till end of life. So, as doctors, we need to be aware that we need to start referring patients at a much earlier stage. Now the theme for this year is Healing Hearts and Communities. Very, very relevant because post-COVID, a lot of changes happened not only with the patients but the families, the caregivers, the community, all of them underwent various levels of distress, bereavement and other issues. Very relevant theme, and taking this theme forward, this palliative care team has done an excellent job here and given us the opportunity to connect with you. I don't stand here as a radiation oncologist, but as a part of the palliative care team. Radiation oncology, we deal with 40% of the advanced cancer patients because they come to us at different stages for palliation. But after that, when we send them back for various conditions to the palliative, they take such excellent care and make sure that the end of journey for the people is very, very stressless and relieved. So, thank you so much for calling.
Thank you so much, madam.